I want to thank Cassia Branicki for coming and joining us today. Cassia is a nurse practitioner with the Regional Palliative Consultation Team. And, over the course of the series, we've talked about a palliative approach to care and community resources, and then kind of symptom management related topics. And today we're going to be talking about end of life care. So really grateful to you, Cassia, for coming.
Thanks, Val, for the introduction, and I'm happy to be here to talk about some changes that happen at the end of life and care strategies that can be incorporated. So I'm a nurse practitioner, as Val mentioned, with the Regional Palliative Consultation Team. Some of the objectives that we'll cover today are identifying signs that indicate a transition to the end of life, some changes that we can see at the end of life, and those care strategies that are associated, identifying when to discontinue vital signs, and familiarizing ourselves with some community protocols or forms such as the DNR form, the EDIS protocol, and the funeral home transfer form. So how do we know somebody is transitioning to the end of life? So in the palliative care world, we often hear of the PPS, the Palliative Performance Scale, and that kind of helps to give us a picture of where that individual is in that moment in time relating to some domains such as ambulation, activity level, self-care, intake, and their level of consciousness. It can help with prognostication in somebody with a cancer diagnosis, but not for individuals with a non-cancer diagnosis. So for somebody with a cancer diagnosis, typically signs of transition towards the end of life would be a PPS of 30% or less, and that's highlighted here. And within that PPS, we also see a lack or decrease of oral intake, sometimes a change in cognition, and sometimes we can see delirium present as well. For those non-cancer diagnoses, so cardiac causes, lung disease, and so forth, we typically can see more of a kind of like up and down in their condition versus that line going down with somebody with a cancer diagnosis in terms of their PPS status. And typically we would see a PPS status of 20% or less being more indicative of a sign to transition to the end of life. And we would also look for weight loss, and sometimes we could also see repeat admissions to hospital or exacerbations managed in the home, such as pneumonia exacerbations, congestive heart failure exacerbations, and so forth. And we often will see symptoms related to that underlying disease becoming worsened, such as worsening dyspnea. The PPS can also be helpful in determining hospice eligibility and just painting an overall picture of how that individual is doing. So the changes that we'll be talking about will range from months to hours to days of that end of life trajectory. The psychosocial and existential needs of an individual can kind of, fit into that picture of months, but also surface more in when somebody's closer to the end of life. And it's important to assess somebody's readiness or willingness or openness to know where they are in that trajectory, and also in identifying changes that we're seeing and assessing. Do they want to know what these changes mean? Do they want to know that these changes are indicative of a transition to the end of life? And sometimes with opening that assessment and opening up that conversation, this is where those psychosocial needs and existential needs may surface. And sometimes we'll see fear of death, guilt surface, remorse, need for self-forgiveness or to receive forgiveness from others. And also just, some issues around meaning. And then depending, on where they are at, interventions would vary from, assessing their spiritual needs, assessing the need for multidisciplinary team approach, involvement of social worker, involvement of counselors, volunteer work to help with legacy work, and so forth. Mentation can also change. Attention span can shorten. And again, we're looking here at months to days to hours of end of life. And with that shorter attention span and the difficulty to process information, we would really want to make sure that our instructions are brief and we allow time for processing of that information, and expect that visits may take longer. So make sure that we're allowing for longer visits as that mentation is changing. We may also expect that individuals may doze off during visits. They may doze off more frequently during the day, and that increased sleep need may be present. And then the hours of sleep may move from sleeping 8 hours total in a 24-hour period to 12 to 16 and so forth. Individuals typically will move from a sleepy to lethargic to obtunded to semi-comatose, and then to closer to the end of life, a comatose state. Delirium can be common at the end of life, and sometimes we can see an unexpected rally happening at the end of life as well. Allowing residents to sleep when they're tired is important, and really being in tune to those cues when they are getting sleepy, maybe during one of those lengthier visits, to allow that we may not check off all our boxes in that assessment piece in that first visit, and we may have to split some visits up. Offering a calm environment is also helpful. And with that unexpected rally, so sometimes when somebody is closer to the end of life, we can see, one day they're sleeping, they're not eating, they're not drinking, they're even bed bound, and then all of a sudden they wake up, they eat a full breakfast, they're talking with their loved ones, and they want to get up and use the bathroom. And sometimes for families, they see this as, this hope that things are changing, and maybe we're not transitioning to the end of life. And perhaps that could be the case, but if we do know that this is likely the end of life, and this could be that unexpected rally that we sometimes see, the importance of education to family could allow them to really understand that this may be that last moment that they have with their loved one to, share stories and speak, and understanding that this can change back to the previous baseline, and sometimes we can even see a really quick decline after this unexpected rally for individuals. We can often see changes to intake, appetite, and swallowing from months to days to hours of the end of life. Anorexia, so appetite loss, and cachexia, weight loss. Cachexia can be seen in cancer commonly, but also in chronic diseases like heart and lung disease. And it's important to address the fears that of starvation, that people have these preconceived ideas that when they stop eating, or when that desire for food stops, that they will starve to death. And also to discuss the lack of effectiveness of artificial nutrition, and that cachexia is not reversible, and pushing food will not reverse that cachexia. We often still see that the weight loss continues, and that pushing food can induce other symptoms like nausea, fullness, vomiting, etc. So a lot of teaching that needs to happen around that piece. The ability to swallow can decrease. Individuals can lose the muscles that help with swallowing. They can start to cough with intake, become at risk for aspiration, and have difficulty swallowing pills. So it's important to assess somebody's ability to swallow and offer alternative ways to give essential medications. So medications, let's say for pain, if somebody's already on opioids for pain related to their cancer diagnosis, and ensuring that we move to a route that's more suitable, such as subcutaneous, to allow their pain to be well controlled, and then to eliminate non-essential medications, vitamins, anything else that wouldn't be within the goals of care for comfort, if that's where things are at. And then mouth care and oral exams we'll talk a little bit more about later. And then also for the diet. So if somebody's moving towards more of a comfort focused care, and we're understanding that these changes reflect transition to end of life, then we really focus on a diet to reflect the individual's preferences, which might mean eating ice cream for breakfast if that's what they want. Xerostomia, so dry mouth. So this can be as a result from decreased oral intake. It can result from dehydration, and it can also result from an underlying diagnosis or past medical history of like radiation to the head and neck. Can happen along the trajectory towards end of life for months, and worsens kind of closer to the days to hours of death. For somebody that is still swallowing or not swallowing, saliva substitutes are appropriate. So they come in spray bottles, gels, rinses. The spray bottles are nice because you can use them, patients can use them independently, or families can offer it to patients or residents as well. Running a bedside humidifier may be appropriate for individuals. If somebody's already on oxygen, putting humidification on that can be helpful. If somebody can still swallow, offering things to stimulate saliva production like xylitol products, so xylamelts, xylitol chewing gum, xylitol candies. And I say xylitol because we really want to avoid sugar in these things to contribute to good oral health. And then mouth care. So individuals that can no longer swallow, can no longer take sips of water. Sponges, like you see in this picture, can be useful, dipped in water, or dipped in water mixed with non-alcoholic mouthwash. I just wrote non-alcohol there, but it's supposed to say non-alcohol mouthwash. Can offer some benefit as well. And then also, if these swabs are not available in the retirement home or to family, then using a soft bristle toothbrush would be fine as well, or even like a washcloth just dipped in some water as well. At the end of life, the lips can also get quite dry, and putting just, whatever chapstick that is available to that resident routinely with the mouth care would be helpful. And Vaseline can be used, but not if somebody is not on oxygen. Oops. Sorry, I just moved backwards here. Changes to the physical changes can also happen. So physical weakness and a lack of energy. Functional decline as somebody transitions to the end of life. And also we can see that, there's a transition from walking to bed chair bound, and then ultimately to bed bound as somebody is closer to the end of life. It's important to create an accessible space for that individual, whether that's in their retirement home room with getting a commode in place if they can no longer make it to the bathroom but still wish to get out of bed, offer a urinal or a bedpan. Determine whether a hospital bed may be more comfortable, more appropriate if they're needing to lift their head up and down. Do they need OT, PT referral for a wheelchair if they're still wishing to get out of bed for comfort? Or, to assess for bed rails, grab rails, things like that. Ensuring that call bells are within reach to prevent falls as they're getting weaker. Encouraging alarm pads or bells if those are available, and if the individual is a fall risk. Joints may become stiffer as somebody is more bedbound. This can cause discomfort as well, and teaching family passive range of motion exercises can be useful, as well as massage. And then interventions to prevent skin breakdown if somebody is bedbound, such as a specialty mattress, and turning in the bed is encouraged, and teaching families to do that as well. Fatigue can become typically does become a challenge for individuals as they're in that end of life period. And unfortunately, it's an area where we don't have a lot that we can do for. Often we'll talk about energy conservation as something that can be done with individuals, and that would look like focusing an activity that's important, focusing on an activity that's important for them for that day. And let's say that's, you know, going to the dining room to have a meal with their friends. So the focus for the day would be that, knowing that it'll likely take energy out of you, and that it's then okay to rest after that. So just prioritizing goals and activities for the day. I was just looking at two screens because mine has the answers. I was hoping that this one does not. Okay, so bowel and bladder changes can happen from months to days to hours at the end of life. And this is resulting from many things, but a big impact is the intake decreases, the output as a result does as well. Are regular bowel movements a priority? So regular bowel movements are no longer a priority at the end of life. True or false? Any guesses? Shannon says false. Correct. It is a very big priority at the end of life. We want to ensure that bowel movements are still happening. So constipation can become a challenge. It is true that with less intake, you'll likely have less output. So the bowel movements might not be as frequent or as much as they used to, but our goal is still to have a bowel movement every 3 days. So it's important to get bowel protocols in, especially in retirement homes, as individuals typically no longer can, track these things independently as they're transitioning to the end of life. And that might look like, if they're still able to take PO medications, then we continue those laxatives, but having something in place, if no bowel movement in 3 days, then give a Dulcolax suppository PR. And then typically those follow with other things like enemas. So really monitoring that and knowing that constipation in itself can contribute to agitation, to delirium. Val?
So I was just wondering, so if you have the scenario where they can't have PO intake, and um like what you described was if no bowel movement in 3 days, Dulcolax suppository. If
Yep.
they're off all orals, would you just keep that up like every 3 days kind of thing?
Yeah, you would. You would. And let's say the individual is actively dying, then we would use our clinical judgment in that point in time. If it's day 3, we're expecting the resident to pass, today, then we would probably just hold off, type of thing. Yeah. Yeah. But usually we keep the suppositories going every 3 days if they are not able to take anything in PO. Mhm. So we can also see a decreased urine production, and that's due to both decreased kidney function and decreased fluid intake. We can also, so then we can expect to have less urine produced, but also we can expect to maybe see retention of urine. And that could be related to some of the medications that residents are taking specific to the end of life, like anticholinergics, other medications that can cause urinary retention. It can also be caused by other comorbidities such as BPH and other things as well, and to assess for bladder distension at each exam. So if you're listening to the bowels, have a look, palpate the abdomen, and make sure that bladder is not distended, or if somebody's presenting with agitation, assessing for that as well. We can see more incontinence of urine and stool, and we would consider things like incontinence pads, briefs, and sometimes a Foley catheter as well. And sometimes at the end of life, there's a loss of sphincter control, and we can see more incontinence closer to the end of life. And encouraging peri-care is important as well. So delirium is common at the end of life, and especially in the final weeks of life. Does anybody know what percentage of the dying patient, dying resident, dying individual may experience delirium? I know this question was asked in a previous presentation, so it's seeing
Not
if everybody was listening.
that I can't remember.
I mean, it's probably a bit different depending which source you're looking at. 40%, 90%. Yeah, so Carl said 90%, which is very close. Depends where you look at, 85%, up to 85%. Some sources, one source said 88, so very high incidence of delirium. I'm not going to get into delirium, the nitty-gritty, because there's already been a presentation, but I will bring up a few things around confusion, agitation, and delirium. So as somebody progresses to the end of life, months to days to hours, we can see more confusion, may not be alert and oriented to person, place, or time. Agitation can be common and not in the context of delirium or in the context of delirium. Agitation has many causes, so it's important to assess, get a good, thorough assessment in there if somebody is agitated, and that would look at the whole system. So are they constipated? Are they retaining urine? Are they in pain? Are they dyspneic? Do they have a wrinkle in their bed sheets that's causing them this agitation? And trying to see if that fixes it. With delirium, there's hypoactive delirium, mixed delirium, and hyperactive delirium. Delirium is an acute onset. It has a fluctuating course, and it usually has, it's an acute onset with or without a fluctuating course with inattention, and it usually has features of either altered level of consciousness or disorganized thinking. And it can be, the CAM tool is a good tool to use as a screening / diagnostic tool for delirium. If delirium is not responsive to medications, it can be referred to as refractory agitated delirium. And that's when sedation can be considered if it's within the goals of care of the individual and the family. So we always want to assess the possible causes, as I mentioned, and safety always comes first. Our goal is to always preserve the patient's dignity, to reduce that agitation, and to ease any negative hallucinations or delusions or restlessness that could be causing that resident distress. Our first go-to is always non-pharmacological. And then if things are still not settling and patient's not safe, not comfortable, then that's when we can move to medications. Symptom response kit. So if you look at the symptom response kit and the orders, they make it pretty easy. Okay, so you have categories of the indications. So here for agitation and delirium, you see that Haldol, midazolam, and methyltrimeprazine Nozanan are available to treat agitation and delirium. And typically for the Haldol or the So for Haldol and methyltrimeprazine, you typically have one or the other ordered, and typically you always have the midazolam available. So if you're needing to use medications, you can use the medications that are in the SRK or in the resident's medication profile if they don't have a symptom response kit in place. And if things are not resolving, you have access to call the RPCT if needed, if the MRP needs more guidance. So I've covered that just briefly because, again, there was a delirium presentation recently. So changes to breathing can happen at the end of life. And this is looking at more specific to those last hours to days of life. So we can see normal breathing become more irregular with periods of apnea present, so periods of breaks to the respirations. We can also see Cheyne-Stokes respirations, which is a crescendo, decrescendo type of breathing pattern where the breathing is very fast and more shallow and slow, and then that period of apnea happens. And then we sometimes will see the agonal respirations, those reflex respirations where it looks like somebody is gasping for air. So it's important to provide teaching around this, to normalize it, that this is normal breathing at the end of life. We don't need to do anything for it. We just need to recognize that it means that the end is near. And again, that can be hours, that can sometimes even be days. And it's also important to note that for some people, apnea can be a normal part of their breathing. So to know whether or not they've had apnea before versus is this a new apnea that's indicating that end of life is near. Oxygen, if the resident's not on oxygen at their baseline, then we don't typically recommend it at the end of life. Hypoxia is a normal change that can happen at the end of life, and it does not require oxygen. So oropharyngeal secretions, also known as noisy breathing, terminal secretions, or the death rattle. These can happen in the last days to hours, the end of life. Again, education and reassurance to those at the bedside that this does not cause the individual experiencing it any distress. It causes those witnessing it distress because it can be quite noisy. Often our first go-to is if IV fluids, feeds, things like that are not discontinued yet, we're at a stage where the end is near, we would discontinue those things. And we can offer repositioning to allow those secretions, which is basically a collection of saliva fluids that are kind of just making things noisy as the individual is breathing in and out through vibration, repositioning them on their side and allowing that to drain. We don't typically do suction or deep suction with comfort in mind. And we can offer medications for this if repositioning is not enough. These medications will not dry out what's already there, but they can help with future decreasing the future oropharyngeal secretions. And in the SRK, you'll see here that both scopolamine and glycopyrrolate can be used for these secretions. It's one or the other typically. Glycopyrrolate is less sedating than scopolamine. So dyspnea is a subjective experience of feeling short of breath. Typically, if somebody was dyspneic before their end of life period, let's say related to lung disease, then we expect that may continue in their end of life phase. If they weren't dyspneic before, then it's really unclear, but we may not anticipate that to be a change that happens. So for the non-pharmacological interventions for dyspnea, we can offer a calming presence. We can allow for airflow, whether that's with a ceiling fan or an open window. A fan position on the side of the face to stimulate the trigeminal nerve can help relieve dyspnea. Meditation and relaxation therapy, playing music if that's helpful for the individual, repositioning if that's helpful for the individual, and oxygen, typically if they're already on it, would be appropriate. But at the end of life, like I mentioned before, we don't typically start oxygen because dyspnea is a subjective experience as well. Pharmacologically, opioids are our first line. And then we also have options in the symptom response kit for Haldol, methyltrimeprazine, and midazolam. And again, very helpful in the SRK. The dyspnea, little check marks tell you exactly which medications work for dyspnea. So we always start with our opioids, and then we can move to other agents if the opioids are not working. Also, I'll just highlight that midazolam at a high dose, even though it's not indicated here for dyspnea crisis, it is also utilized for that. They just ran out of space here, but it is included on the second page of the SRK. So pain, typically at the end of life, if pain was a challenge for the individual before, then it likely continues to be so. And we continue any medications that resident was on before and change routes to sub-Q as necessary. We offer repositioning, specialty mattress if they have any alterations or risk for skin breakdown. We assess for opioid toxicity, so hallucinations, myoclonus, which is like a twitching that can be seen as a opioid toxicity. And we continue to assess signs and symptoms of pain with different pain scales that are available, which I'll highlight in a moment. And sometimes we need to make changes to pain medications as we go along in the journey. So different pain assessment scales exist, one of them being the FLAC, one of them being the Pain AD for advanced dementia. And sometimes I like to show these to families as well. So because, you know, they're often there at the bedside a lot more than we may be, it gives them the opportunity to understand what pain might look like when somebody cannot verbalize it, and then to notify staff as necessary. And then again, in the SRK, you can see here, pain, hydromorphone or morphine, but if somebody was already on something, then we would use what they were already on. And if they were on something PO, then we would switch it to sub-Q by dividing that dose in half. So if they were on 1 milligram QNH PRN PO, we would move that to 0.5 QNH PRN sub-Q hydromorphone. We often see circulatory changes, specifically to the last hours to days of life. Skin can become cool, clammy, pale. We can see cyanosis, and we can see some mottling sometimes, not always. And interventions for the cool, clammy skin would be to change the bedding if it's damp, remove blankets for comfort, add blankets for comfort. If the individual has a fever, we could offer a cool cloth. And if they're looking like they're in distress from that fever, we can offer Tylenol PRN suppository if needed. And we don't use electric blankets or heating pads typically. Do we discontinue vital sign monitoring? I see a thumbs up. Yes, so the big question is always like, what will we do with this intervention? Like, whether that's an x-ray or vital signs, if we take a blood pressure, what are we doing with that? Probably nothing if somebody's goals of care are for comfort only. So we tend to discontinue vital signs when somebody's goals of care is changed to comfort and they're in those final days of their life. At the end of life, the ability to close eyes can be lost as well, and this can be a normal change, and we can offer support with lid care And that can be taking a cotton pad and just gently wiping the eyes. And it could also be with ocular lubricants such as artificial tears or even sterile saline. Sensory changes can happen along the trajectory as well. There can be an increased sensitivity to light. So we like to avoid bright lights, dim the lights. There can be a decrease in visual acuity as well. And it's thought that the sense of hearing is the last sense to go. So we often encourage, if the resident enjoyed listening to music, to country music, to play that music for them. If they get agitated when you play it, well, then turn it off. We also encourage to be aware that even though somebody's eyes are closed, they might still be able to hear us. So just be sensitive to the conversations we're having around that individual. And even as somebody is actively dying, to encourage speaking to those residents, because there is a possibility that they could still hear us. How do we know death has occurred? Seems like a very straightforward question, but how do we confirm this? Any thoughts?
I'm thinking cessation of breathing.
Yeah.
Shannon says a lack of pulse, no being able to auscultate any heartbeat.
Exactly. So this was supposed to be in the next slide, but this is the DNR form. So we want to make sure this is in place. If somebody is at the end of their life and their goals of care are for comfort, and if it is in place, then we know we will not be providing any CPR. This is typically found in the chart in the home, but also in the retirement home chart. And it's typically a copy in one of those places. We usually like to keep the same serial number within those two locations. And I'll just highlight here that, so name has to be filled out. One of these boxes needs to be checked. And what I sometimes notice gets missed here is that the individual that's signing the form needs to check one of these boxes as well. So whether they're an MD, RN, NP, or RPN, and then sign their name and date. So all those things are in place, and we notice that the resident stops breathing. Their heartbeat is typically also not present. Their pupils are typically fixed. We notice that their color turns to a pale color. Their body temperature drops. Their extremities are cool. Their muscle sphincters relax, typically releasing stool, urine. The eyes can remain open at the end of life, and the jaw sometimes will fall open. How to pronounce a death. So as Val mentioned, auscultating. So to pronounce a death, it would either be a nurse or or a physician or nurse practitioner. And I'll show you the Edith form after. But to pronounce a death, you would auscultate the heart for 1 to 3 minutes, absence of a pulse for 1 to 3 minutes, absence of any breathing by auscultation for 1 to 3 minutes, and then pupils would be fixed and dilated confirmed with a pen light. Once a death is pronounced, the date and time of death would need to be documented. Depending on the retirement home, some retirement homes have their own policies that the nurses in the retirement home can pronounce. Other retirement homes will call the agency nursing in to do the pronouncing themselves. If the retirement home is doing their own pronouncing, then we just ask for home and community care to be notified, for any services that are in place to be stopped. And then the MRP can be notified. If it's a death that happens overnight, then that can happen the next business day. And the funeral home typically needs that certificate of death within 24 hours by the MRP. So here we have the Edith form. So the Edith form is an expected death in the home form that would indicate who would do the pronouncing for an expected death. And if you look down here, this is how you would kind of determine who is pronouncing if an EDIS form has been completed. If the physician or NP is pronouncing, this box will be checked off here. And if the nurse is able to pronounce, then box number 2 will be checked off here. It'll be signed. And then typically the MRP's phone number is, I don't know if you can see my cursor moving. Under the okay, you can't, that's okay. Under the pronouncement plan, the physicians or nurse practitioners, the MRP's phone number will be there, and that's the individual to contact to notify that the resident has passed, and that can happen the next business day. At the time of death, it's important to follow through with any important rituals that are important to the patient or family, to assess the family for their wanting to participate in any care of the body after death, to allow family time with the deceased if they wish at the time of death, and to ask the family if there's maybe anybody else they would like to be called to come in, and to ask the family how long they plan to be at the bedside for funeral home planning as well. The other piece that typically is filled in by agency nursing or retirement home staff, if that's within their policy, is the funeral home transfer form. And it's pretty straightforward on there what needs to happen. So that's it. A lot of information in a very short amount of time. We have a 24-hour call line that's available for healthcare providers if there's any need for pain and symptom management after hours. And during business hours, we have our office number that we're always happy to take calls at. Any questions?
Cassia, have you had the chance to support residents in retirement homes dying in the retirement home?
I have.
And what are some of the things that make it go well, and what might be some of the challenges to that?
Yeah, so I mean, things that go well, typically I would say staff that have experience and education in palliative care, and also the knowledge that they can connect with us if needed. Typically also if there's a clear plan in place and what to do when somebody passes. Sometimes we do get calls on the after hours line from retirement homes where maybe there wasn't as much clarity around that. But yeah, I would say those are the key things that I've noticed.
I was wondering about the DNRC form.
Okay.
Have you had the chance, are they, again, more typically situations where does the resident already have a DNRC in place, or it happens as you're planning for end of life care at the retirement?
Yeah. Oh, it really depends. Like I don't feel like that's any different from the home to retirement home setting. It all just depends on, like, when a resident gets I don't know if I should use the word admitted, probably not. When a resident moves into a retirement home, there's typically maybe not goal of care discussions, but I'm trying to find the word, but
advanced care planning.
Advanced care planning that takes place.
Yeah.
And in there's been some sort of conversation around advanced care planning, whereas in the home setting, maybe not as formalized of a process. So I haven't really noticed much of a difference in when a DNR is filled in more frequently or less frequently in the home setting to the retirement home setting. Personally, sometimes what I've noticed is I find a DNR in the chart in the home in the retirement home, but then I don't see it in the retirement home chart, or vice versa kind of thing. So I have noticed that. And then typically we just make a copy of it and then inform the retirement home that, this resident has decided that they do not want CPR, and the DNR form has been photocopied and placed in your retirement home chart. Mhm.
I was going to ask a question if that's okay. Um,
Mhm.
we're talking more about the SRK kits in retirement homes and where to store them and that kind of thing. In your experience, where has it been stored the most effectively? Like where has it been and what do you recommend essentially?
I typically see it stored in with the nurses at the nursing
Okay.
station. Yeah,
Yeah.
that's I trying to think if I've ever had it in the room of the patient like we do in the home setting, and
Hmm.
I don't,
Not so much.
not common. No.
Okay.
Yeah.
I guess it doesn't matter how close or how far the room is to the nursing station. It's just always best there.
Yeah, I mean, would there be a reason why you feel like it might be better in the room?
No, I just know that we're going to be asked to be a little bit more diligent when it's being requested, and so I was just putting some thought around that.
Okay, okay. Like let's say shift nursing is in place, then temporarily for that period of time, if there's a policy that the retirement home can put in place, um, to allow the shift nurse to take the medications so that it's easier
Yeah,
for
that's
them,
right.
perhaps
Okay.
maybe that. But
Okay.
I know that also the shift nurses sometimes will just pre-draw meds at the nursing station and
Hmm.
then bring it to the residence room that way.
Okay, that
Um,
makes sense.
yeah,
Okay.
yeah, I
No,
feel
thank
like
you.
the nursing station is probably the best place for it in the retirement home setting.
Hmm.
Um,
Okay.
since the nurses are typically the ones that are drawing up the meds anyhow.
Yeah. All right.
Mhm.
Thank you so much.
No problem.
Any other questions or comments for Cassia? All right. Well, I know. Oh, Sophie, did you?
Yeah, I just want to add a little point. So you did mention about photocopying the DNR sheets. In my past, I actually was told that we cannot photocopy the DNR sheets because they are a ministry form specific to a resident. So for example, like paramedics or whatnot would not accept a photocopy of a DNR sheet, like they want the original. So just maybe
Yeah.
just that point. Yeah.
Yeah, they do. You're right. They do want the original. So on the photocopy, we'll often write like original copy in chart in the home or vice versa, original copy in the retirement home chart. So they
Okay.
don't want a photocopy, but my understanding was that they also do not want two separate copies with the two separate numbers on them. So
Yeah,
for each
exactly.
patient,
Okay.
it's all blurred out, but
Yeah,
each
no, I get
resident
it.
should have just one form with one number on it. So how
Yeah.
we've kind of gotten around that is to write on the copy, this is a copy,
Yeah,
original
yeah, yeah.
form is
Okay.
located here.
Makes
And
sense. Yeah.
sometimes even in the home setting, families will make copies and just keep them in their purse. But it is a
Yeah,
copy, and if something happened out of the home, would the paramedics be able to use that copy? That's a
that's it.
good question. Yeah.
Okay.
Mhm.
Thank you.
No problem.
All right. Well, I want to thank you, Cassia. I hope this was helpful for the folks that were here online with us today. And then you'll be up in lights on our YouTube channel before you know it. So we'll look forward to serving the community in that way too. So, and I'm seeing some consistent names who've been here throughout the series. So thanks so much to all of you for taking time out of your busy days to join us over the past many months.
Thank you. Thanks, Val, and thank you everybody for joining.